Hey, my friend, what's up? On this episode, I bring to you the world's top expert on lipids, which are fat, cholesterol, and a whole lot more. So if you've ever been confused on your blood test by what the heck is HDL cholesterol, LDL cholesterol, triglycerides, and more, you gotta listen to this episode because this world expert is gonna describe it all for you. In fact, he will even tell you the one extra test that you should be getting every time you go to your doctor, but you're likely not. This test determines more than any others your risk of heart disease. And the shocking part is most doctors don't even check for this test. Stay tuned for an exciting episode. And if you're enjoying the show, please make sure to hit the subscribe button down below so you can get notified when we release new episodes. Our goal is to give you information that will help you look and feel younger and slow down your aging. Hello, everybody. Welcome back to the Anti-Aging Hacks podcast. Today, I have a very, very special guest. His name is Dr. Thomas Dayspring. He is both a fellow of the American College of Physicians and the National Lipid Association and is certified in internal medicine and clinical lipidology. After practicing in New Jersey for almost 40 years, he moved to Virginia and served as an educational director for a nonprofit cardiovascular foundation and later as a chief academic advisor for two major cardiovascular labs until mid-2019. Currently, he's a cardiovascular educational research assistant and clinical lipidologist at Atea Medical. Career-wise, he has given over 4,000 domestic and international lectures, including over 600 CME programs. Until 2019, he was an associate editor of the Journal of Clinical Lipidology. He was the recipient of the 2011 National Lipid Association's President's Award for services to clinical lipidology. He's very active on Twitter and has well over 15,000 followers, and he can be followed at Dr. Lipid, at Dr. Lipid. And I just want to reiterate that this is one of the world's preeminent experts in this space, so I'm delighted to have him on. Tom, welcome to the Anti-Aging Hacks podcast.
Well, thank you for that nice introduction, and it's my pleasure. I love spinning lipids, as you know, so let's go.
Yeah, I've been nerding out a lot on your content, so I'm excited to dive in. So Tom, as a means for the listeners to get to know you a little bit better, tell the listeners about your background and how you got so interested in such a complicated topic such as lipids.
Who knows? I'm a Jersey boy, as we like to call ourselves, born and raised in northeastern New Jersey, grew up there, public schools, Rutgers University, and at the time it was called New Jersey College of Medicine, which has since evolved into a division of Rutgers. So I never made it very far from home with all my education and everything. And my dad was a fireman, so I always sort of loved emergency things. And actually going through medical school, I worked on the local city ambulance, which got me involved. But once you start medical school, how did I wind up in lipids? I joke. In freshman biochemistry, they assigned a term paper to each student. And the professor asked me to investigate and write up something called A-beta lipoproteinemia. Now, this is 1968. We barely knew what lipids were back then, and certainly didn't understand the concept of lipoproteins. But anyway, I had to read about it. And I'm always saying somehow that got into my brain, and I was always fascinated with lipids and lipoproteins. After I finished med school and clinical training, those were the golden years when a lot of lipid discovery was occurring. And instead of just looking at total cholesterol, they started to look at lipoprotein subfractions cholesterol. Framingham's study, Mr. Fit, came in and clearly related it to cardiovascular risk. So to me, not only, hey, this is important to know, but we have the potential to maybe save a lot of lives if we really know what we're doing with this. Now, that took another 20 years for all the information to come down the pike, but I just jumped on it right away. And even during my internal medicine training, cardiology was a subspecialty that fascinated me the most. Those were the years when Mason Sones had invented coronary angiography and hospitals were starting to do it. And that was like, God, what a cool thing. We're sticking things into people's hearts and looking at it. The evolution of coronary care units developed back then. And that was like the cool place to hang out as a resident. You really had to be a smart guy to do good down there. So right. I just loved cardiovascular disease. And I'll finish this up. But once I went into private practice, as a resident, you don't care whether you sleep at night. It's kind of fun to be up in the hospital and running all through the halls. But once you go into private practice, you cherish your sleep. And of course, if you're an internist, what are all the 2 and 3 and 4 a.m. phone calls? Heart attacks back then in the mid 70s. And so you got to get up, rush to the hospital, pray your patient survives by the morning, because there wasn't a lot we did back then. And I just got into my brain again, God, if I could really master atherosclerosis and the events related to it, I might actually get to sleep a little bit as an internist. So it just was a topic that always fascinated me. And I pursued it with a vengeance, meaning much of my reading and interest in education was on lipids and atherosclerotic disease. And in the mid 90s, I got a chance to, hey, you seem to know a lot about this. Why don't you go out and start talking to other doctors about it? And I did. And God, within several years, I became one of the most requested educators and started writing and publishing. I have a knack for words. So here I am. I have no idea how this all worked out. It wasn't by design, but now I'm in the crescendo of my career. Twitter has made my existence a lot of fun because you can just type it on your computer. You don't have to get on a plane. Mm-hmm. And the podcasts are a great way to get in front of people also. So that's my short story.
Yeah, well, thank you for sharing. I think the world is a lot better off with you sticking to this field and contributing as much as you have. Folks, I've been following Tom on Twitter, and he gets into very spirited discussions, and he's a very well-known educator, especially on Twitter, and some of the slides that he shares are dense, but once you understand what's going on, it's just a pleasure to read and understand this complex field from just synthesized down from his expertise. And so, Tom, you've been in this for 50 years or so. Like, what's changed since you started, when all of this data was starting to come out and you were measuring actual metrics and understanding lipoproteins? What's changed over the years, over the decades? And now, where are we at with this field? Are we at the cusp of understanding everything, or are we still out in the woods?
We'll always be out in the woods, but we're a lot smarter than we used to be in my early heyday, that's for sure. But the biggest evolution is the recognition of the various causes or etiologies of atherosclerosis, the formation of cholesterol-laden plaques in the artery walls that lead to all the nightmare endpoints that we don't want to experience, because many of them can kill you or make you quite ill. So the initial part was recognizing what is it that I, as a clinician, can measure in the blood. And then once you go beyond that, you really just start learning a lot more of the various pathologies that are occurring. That has evolved tremendously over time. Once we started to understand it a little bit, the next revolution was they started to look at, all right, we think we have an understanding of what causes this terrible disease, but what can you do about it? And therapeutics started to be evolved, and they were quite good, and they've evolved tremendously. So in my heyday, where there was, even when I started to understand, I think you're going to have a heart attack, there was almost nothing I could do about it. And that's changed a hell of a lot. We got a lot of stuff we can throw at anybody now. And in fact, I believe if I pick up the newspaper and look at the obituary column today, and you see people who are less than 70 years old and they died of a heart attack, I think that's a shame, unless they had some super rare genetic condition where they probably would have died a lot younger. There is no reason to die or have morbidity related to atherosclerosis anymore. And so that's how far we've advanced. We have the tools that can prohibit that. And of course, our understanding gets better and better. I think the future is going to be, and I'm glad it's even beyond my trying to understand, is going to be the genetic approach to everything, and see how these genetic tests that are coming down the pike can help us not only ascertain risk, but perhaps better design nutritional and pharmacotherapies.
Well, that's great, Tom. And I want to just, for the listeners, I'm going to lay out what we're going to be discussing. There's just so much we could talk about. And as I've been emailing with you over the last few days, we've had lots and lots of questions. We've kind of whittled down to a 2-part interview where for the first part, we'll talk about the lipids, basically a definition, set the nomenclature so everybody's on the same page. We'll talk about cholesterol, triglycerides, and we'll very briefly touch on defining atherosclerosis, which you just mentioned. And we'll talk about it in the second part in a little bit more detail, along with LDL, and some more metrics. And then to round out the first part, we will also talk about the standard lab tests, which you go and get with your doctor every year if you're getting a test, and what those really mean and what's missing from an expert standpoint on those tests. So if that's okay, Tom, let's dive right in and talk about the definitions of lipids. Let's set out the nomenclature so we're on the same page.
Sure. So lipids are organic molecules, obviously, that the simplest definition is they are insoluble in water. They float. They don't diffuse. You pour alcohol in a glass of water, you can't see any. You pour oil in a glass of water, and you have different layers. So lipid molecules are water insoluble. And lipids, several lipids, are crucial for human life, cellular life. So cells either have to make lipids or they have to deliver lipids to them. But certain lipids, if they go beyond a certain cellular concentration, can be extremely toxic. So cells have to have a way to evict various lipids, and then they have to be taken somewhere else where the human body can catabolize them or eliminate them. And, the only way humans eliminate anything is urine or feces. So that's what we do. So lipids are water insoluble, crucial molecules. And the most common lipids that most people can rattle off the top of their head, everybody has heard of cholesterol. Cholesterol is in a rather large group of lipids that are called sterols. For those who know a little biochemistry, they're ring structures with some other molecules sticking off of them. They're called aromatic. And anything that has four rings and has these extra molecules tagging off of it is a sterol. Now, there are many sterols. Sterols are absolutely required for human life, but the only sterol required for human life is cholesterol. And humans and the animal kingdom are very good at producing cholesterol because you'd be no life if your cells couldn't make cholesterol. In essence, if the animal kingdom makes them, they're called zoosterols, zoology being the animal kingdom. Now, plants are obviously living structures. And for the most part, there are a few exceptions. Plants don't make cholesterol, but they need sterols for many, many functions. And they create things that look almost exactly like cholesterol, but they're subtly different if you're a biochemist. And they're called phytosterols. Now, humans don't need phytosterols. We're not plants. But we eat plants all day long. So we're swallowing phytosterols. But evolution knows in humans, beyond a certain level, phytosterols can be toxic to humans. So they are not absorbed in most humans. So cholesterol is a sterol that is required for human life. Why? Its biggest function is it's a participant in the membranes. Those are the layers that surround every cell in your body. And they consist basically of two molecules, cholesterol and another lipid we'll briefly mention called phospholipids. They stand next to each other in the cell membrane. Cholesterol, the amount in your cell membranes and exactly where it positions itself next to which phospholipids is highly regulatory of something called cell signaling. That's how does a cell respond to anything in its exterior, the bloodstream. And depending, you hope it's a good response that will protect that cell, but a defective response could injure the cell. So cholesterol is integral to the functioning of cell membranes. And the other crucial function of cholesterol is certain cells change them into steroidogenic hormones. And of course, those are our reproductive hormones made in the gonads, but we also have adrenocortical hormones, cortisone and other hormones that regulate numerous aspects of physiology. So you need cholesterol to make those. That's why if you had zero cholesterol in your body, well, you couldn't reproduce. I guess we could all hang around for a while without that, but you certainly need adrenocortical hormones to function or so. Now those tissues make plenty of cholesterol to satisfy their needs, but they need so much, they also, in general, have to have cholesterol delivered to them. The key part of every other darn cell in your body is it has the machinery, the synthesis mechanisms to make all the cholesterol molecules it ever needs. Wow. So a crucial concept to understand is that your nose cell, your kidney cell, any cell in your body does not need a delivery of cholesterol. That's why you could have an LDL cholesterol of 0 and suffer no effects. You're not depriving your cell of cholesterol. Remember, LDL cholesterol is measuring certain amounts of cholesterol floating in your plasma. Tells you nothing about the cholesterol in your cells. So an important concept, as we'll get into. So cholesterol is required for cellular, lots of functions. The bad thing about cholesterol within cells is that it is synthesized or somehow acquired beyond a certain cellular concentration. It's an incredibly toxic molecule. Cholesterol, sort of like uric acid and other molecules, can crystallize. And when you get crystals, they're cellular toxic. So if my nose cell is building up too much cholesterol, that cell is going to die unless the cell can say, oh my God, too much cholesterol. Let me get it out of here. And evolution has given our cells powerful abilities to grab cholesterol molecules, and it's called efflux, export cholesterol to something in the blood that will accept cholesterol. They're basically proteins. They're called cholesterol acceptor proteins. And that's how cells get rid of it. And then those proteins can take the cholesterol and bring it to somewhere else where the body can dispose of it or so. So cholesterol is a crucial molecule. It's what we refer to it as homeostasis. That's the balance of having exactly the right amount and the ability to get rid of what you don't need. And the last thing to mention in the cholesterol story is it's in every cell in your body. No ifs, ands, or buts about that. And we have our peripheral cells. We have our liver. We mentioned the steroidogenic tissues. But we also have a pretty important organ called the brain, or the central nervous system. And cholesterol is super essential for it's the predominant lipid by far in the brain. But interestingly, the brain is enclosed in a system, and it has a dividing line between the plasma called the blood-brain barrier. So every neuron, every astrocyte, other cells in your brain needs to make a significant amount of cholesterol. It acquires zero cholesterol from the periphery, from the blood. So that means the brain de novo synthesizes all of the cholesterol it needs. So one never has to worry if make cholesterol in the bloodstream zero, at least in lipoproteins like LDL cholesterol, that I could possibly injure the brain. You can't, because the brain could care less about the other cells or your plasma having cholesterol or not having it. The brain can always make all the cholesterol it needs. So anything we talk later about measuring this type of cholesterol or that type of cholesterol, and perhaps using lifestyle or drugs to modulate cholesterol concentrations, has nothing to do with the brain. So that everybody, you've seen it so much. Oh my God, my whatever cholesterol measurement is too low, my brain is going to die. Your brain could care less. So keep that in mind too. So that's what cholesterol is. It's highly regulated. We either make it, but it is so important. Evolution has given us the ability to absorb it from our gut. So obviously, if something is so important that every cell has the power to make it, but also just in case you need it, your gut can absorb it, that's a pretty crucial molecule. And better yet, if for some reason you got too much in your body and you have totally functioning mechanisms, you can get rid of cholesterol. Of course, if for whatever reason you have astronomical amounts of cholesterol, you may overwhelm the ability of the body to get rid of it, and then you're going to suffer the consequences of cholesterol in various organs. We'll talk to it in part 2, but you know the organ of most concern. You said the word atherosclerosis. There is no disease called atherosclerosis unless there are cholesterol molecules deposited in the artery wall. So atherosclerosis, although affected by numerous forces and risk factors, there is no atherosclerosis unless cholesterol winds up in your artery wall. And it's pretty easy how that happens, but if we could prevent that from happening, there's no atherosclerosis, there's no CCUs, there's no bypasses. So that is such a crucial concept. We got to keep cholesterol out of the artery wall. You know, without cholesterol in the artery wall, doesn't matter if you have high blood pressure, doesn't matter if you're a diabetic, doesn't matter if you're fat or skinny, doesn't matter what your family history is. If there's no cholesterol within the walls of some of the arteries in your body, you do not have that disease. Move on to whatever else is going to kill you. So that's cholesterol. The other lipids that most people look at, certainly when they get their reports back, there's 2. and one is not reported and one is always reported, and there's a lot of noise about it today. Both of these other lipids are in a class called glycerolipids. What they are is a lipid molecule that attaches itself to a 3-carbon sugar called glycerol. Mm-hmm. So if I stick 1, 2, or 3 fatty acids on those 3 carbons, I have a glycerolipid. Everybody has heard of triglycerides. Chemical name is triacylglycerol, acyl being a fatty acid. So I have 3 acyl groups, 3 fatty acids stuck on a glycerol molecule. That's triglycerides. And fatty acids, there's a lot of carbons in those, variable amount of double bonds. They're high energy molecules. So the real function of triglyceride is it's an energy transporter. So if you're eating triglycerides or somehow other organs are making them and they get into the blood, they are trafficked to tissues that use a lot of energy or store energy. Mm-hmm. Muscles, of course, need triglycerides for fuel preferentially. If you're not using your muscles, your adipocytes, your fat cells are happy to store your triglycerides until one day maybe you do need some energy. Right. So that's what triglycerides are, 3 fatty acids on a glycerol. But there's another type of glycerolipid where there's only 2 fatty acids attached to glycerol. And then there's another group in it that has what we call a phosphorus moiety, a phosphorus-containing molecule. So that is called a phospholipid. We don't measure them routinely in the blood. They're super crucial. And what phospholipids are, I hinted at it before, they, along with cholesterol, make up your cell membranes in your body. We're going to talk about lipoproteins in a little while. And the surface of all lipoproteins is a mixture of phospholipids and cholesterol. Mm-hmm. And the distinguishing characteristic of phospholipids and cholesterol, unlike triglycerides, is they have what we call an OH group, a hydroxy group sticking out. So they're slightly water soluble. So that's why they're on the surface of things, because they can sort of be compatible with the water that is in your plasma. Whereas triglycerides is a total oil. Triglycerides cannot exist in any water solution. So that's why you don't have triglycerides floating as free molecules in your plasma. So those are the 3 main lipids. I think most people, when they go to the doctor, they look at various, what I call cholesterol metrics. Their measurement of cholesterol in various types of cholesterol carriers called lipoproteins. And that's what triglyceride is. It's a measurement of triglyceride basically within all of these carriers. And then based on that, because we have all sorts of epidemiologic and trial evidence, we can start to do risk evaluation. Are you the guy Dayspring's talking about where, oh my God, some of that cholesterol might wind up in your artery wall? So we use measurements of lipid concentrations in the blood to help us make that. We've graduated beyond that. In my day, it was all just certain cholesterol measurements. Triglycerides came in, but in the early days, nobody knew what the heck to make of those. And we've evolved from that because we evolved for the following reason. And it's intuitive. So I just told you all lipids are oils. They really can't circulate in your plasma, which is a water or aqueous solution. So how do lipids go anywhere in the human body? If cells have to get rid of them and they got to be taken here, or in some cells, do lipids have to be delivered? How does that possibly happen? Your gut or your liver can't excrete lipids as free molecules into the bloodstream. Oil and water don't mix. So evolution readily solved that problem. It says, listen, if the intestinal cells, the liver cell, or peripheral cells have lipids, once they want to get rid of them, they have to wrap them with a solubilizing agent. And what solubilizes lipids is proteins. Proteins are eminently water soluble. And certain proteins, depending on their amino acid makeup and their curvature, have a tremendous affinity to bind to lipids. So what are the proteins that bind to triglycerides, to phospholipids, and to cholesterol? And if I had a macromolecule full of such proteins, full of cholesterol, phospholipids, and triglycerides, what would I call that? Well, I'd call it a lipid delivery truck, but science calls it a lipoprotein. So you take collections of cholesterol, triglycerides, phospholipids, you wrap them with various proteins, you now have a water-soluble lipid transportation vehicle, and the liver, the intestine can excrete them. If you have a cell looking to get rid of cholesterol, it pumps the cholesterol out into a lipoprotein acceptor, and that's how cholesterol exits the cells. So the simple message is lipids go nowhere unless they're a passenger inside of a lipoprotein. So therefore, what did Tom tell us? He told us, God, if you get sterols in your artery wall, you got that bad disease. So how in the world would a human wind up with sterols in their artery wall? A malbehaving lipoprotein would have to exit plasma, enter the artery wall, and do what we in Jersey call an illegal dump job of lipids, specifically cholesterol in that artery wall. Mm-hmm. And that's how the process starts. So atherogenesis is a lipoprotein-mediated disease. But it's really cholesterol-mediated disease, but it's lipoproteins who deliver the criminal cholesterol to the artery wall.
I got you.
So we now, in today's modern world, can look beyond measuring the cholesterol content of various, or the triglyceride content of various lipoproteins. We can actually start enumerating the concentrations, counting the number of lipoproteins that are actually carrying these lipids around. And of course, through study and multiple clinical trials, certain lipoproteins are far more likely to cause that plaque than others. And you just have to understand that. And you have to understand what lab tests you can do that maybe can clue you in on that sort of thing. Since lipoproteins are regulated by many forces, including something which is epidemic in this country called insulin resistance nowadays, there are certain qualities to the various lipoproteins that would tell an astute clinician that, oh my God, yeah, there are lipid lipoprotein abnormalities here, but the cause is insulin resistance. And the best way to treat that person would be recognize you're dealing with insulin resistance and do whatever lifestyle or pharmacologic tricks you know to get rid of that process or so. Mm-hmm. That's sort of the lipoprotein story, the lipid story. As we get into how you measure these or something, perhaps we should talk about the terminology or how we classify lipoproteins, unless you have other questions right now.
No, Tom, this is great. This is a great overview. I think the two things that people are deathly scared of as they cross 40 is the number of cholesterol, or the name cholesterol, and LDL, which they don't know that it stands for LDL cholesterol. But so these are the two things that we'll get into in this part 2 of this. We'll get into more of detail in part 2. But I think what you just laid out is very, very crucial for people to understand. The different types of lipids are cholesterol, which is essential for every cell in the body. And the body has a way of extracting it or absorbing it from the gut or making it by itself. Mostly, cholesterol has multiple functions in the body, but it also serves as part of the wall, the lipid wall of every cell, which is important to save the cell from all the external aggressors. But also, the second part of this we talked about is the phospholipids, which make up the majority of the cell membrane of every cell. And so those are extremely, extremely important lipids as well. And what Tom rightly pointed out is these things are scared of water. So they're scared of your blood plasma. They can't readily float and get to the cells that need them. So they have to hijack or jump on these dump trucks, as Tom mentioned, with there are different types of proteins that hide them inside of the protein so that they're not exposed to water, so they can basically go into your blood vessels and into the circulation and then come out as needed per the cell. Is that right so far, Tom?
Yeah, that's a pretty decent explanation. And it's a little more clarification on these proteins that I alluded to. And there are several, but proteins that have the ability to bind to lipids and therefore encircle the oil droplets, the collection of cholesterol, phospholipids, and triglycerides that cannot circulate in your bloodstream, are called apoproteins. If you look at them themselves, once they attach to the conglomeration of lipids, they're called apolipoproteins. And they're basically two broad categories. Mm-hmm. Structural, and the main purpose of those proteins is to provide structure, stability, and solubility to the lipoprotein macromolecule. But then there are many, many other apoproteins that sort of come and go. They're on these particles transiently because what they do is the structural apoproteins give you a nice solid structure that can float around your planet. These other ones decide where it's going. The other apoproteins bind to this receptor, that receptor. They interact with that enzyme, which is how the particles get catabolized, releasing their energy, triglycerides, or their cholesterol. So apolipoproteins, once they're on the molecules, are super crucial to facilitating the delivery of lipids or the exit of lipids. You got the wrong type of apoproteins, you're going to have a lipoprotein or lipid disorder, and most of them come with consequences that you rather not have. So apoproteins become crucial. The one that is by far, if you learn nothing else today, the apoprotein that is crucial, because I hope you're going to measure it on your next blood test, is, I guess I could say lipoproteins have the ability to enter the artery wall and dump their cholesterol. They would be atherogenic, causing plaque. But then are there particles that don't enter the artery wall, and therefore I could care less how much cholesterol is in them because they're not going to go pollute an artery somewhere. So there are basically two major categories of lipoproteins. There is one that has one structural protein on it called apolipoprotein B, capital B as in boy, ApoB for short. Apolipoproteins, too big a word. So what are the particles that have apolipoprotein B on them? And this is cool because we're going to measure ApoB in the bloodstream. There is only one ApoB peptide on each of these particles that carry it. Originally, lipoproteins were discovered by a physicist in a centrifuge tube. He took serum, he put it in a centrifuge tube, he spun it like crazy for over 24 hours, and all of a sudden he saw different layers. And he says, oh, those are the lipids. But why are there different layers? Why do some sink to the bottom of the tube and why do others float? Well, that has everything to do with buoyancy or density. If you have a very dense particle, it will sink to the bottom of the centrifuge tube. And it didn't take a genius to say, I'm going to call them high density lipoproteins. If something's going to float on top, it can't be very dense, it's very buoyant. I'm going to call them very low density lipoproteins. And wait a minute, what are these guys in the middle that sort of halfway sink, but they don't go to the bottom of the tube? Well, they're either intermediate or low density lipoproteins. So bingo, that was your original classification. I think most people sort of think, well, HDLs don't really cause heart disease, but we know LDLs do. The modern world knows VLDLs are an equally important contributor to atherosclerosis. So long story short, it's the ApoB molecules that are potentially atherogenic. So the ApoB molecules are VLDLs, IDLs, and LDLs. There are some other genetic things that can do it, something called Lp(a), which maybe we'll get into at another time. But those are your ApoB dump trucks. Those are the potential legal dumpers. They can exit plasma, enter the artery wall, and if they get gobbled up by white blood cells in the artery wall, you now have what's called foam cells. Cholesterol is all over your artery wall, and it leads to plaque and all the complications thereof. Interestingly, the remaining lipoproteins, called high-density lipoproteins, they're really small. They carry very little lipids. So they're not, that's why they're not buoyant. Fat people float easier than skinny people. So the big VLDL full of a lot of lipids floats. HDL has almost no lipids in it, just a lot of proteins. It sinks to the bottom of the tube. HDLs can, guess what, go in and out of your artery wall, but they don't get eaten by the white blood cells in there, contributing to sterol deposition in the plaque. So that's where a long time ago, and based on some early studies, that people thought, well, the HDLs might be desirable, whereas these ApoB particles, and when they discovered them, nobody had even discovered ApoB yet. They were just called LDLs, VLDLs, and IDLs. A couple of decades later, they identified the structural protein being ApoB. So we have two classes of lipoproteins, ApoB and one ApoB per particle, or ApoA1, which is the protein that enwraps your HDL particles. A little more complicated because HDLs per particle can have from 1 to 5 molecules of ApoA1. Unlike the ApoB family, only one ApoB per particle. That's why it's so easy to measure ApoB and directly translate into concentration of particle number, where ApoA1 is a gross estimation of HDL particle number. So it's your ApoB families that are potentially atherogenic. Why did I say potentially? Aren't they all bad? Aren't all LDLs, VLDLs bad? No. Follow me here. You need cholesterol in your artery wall for it to be bad. And sure, it's an ApoB particle that is the dumper of that. But what would happen if an ApoB particle is grabbed by a receptor in your liver and pulled into the liver? That's called clearance. And then the liver would digest that particle and do whatever it wants with the cholesterol. But if a liver clears an ApoB particle, guess where it can no longer go? Your artery wall. Right. So if you told me I know how many LDL particles are in my blood, I'm going to ask you, okay, are they crashing your artery wall or is the liver clearing them? And you would say, how in the world would I know that? And you wouldn't know that without doing super sophisticated tracer tests and everything. But we know there are certain things that probably make it very, very likely that the ApoB particles are crashing your artery wall, and it's particle number. And that's why ApoB becomes such a crucial measurement. So ApoB is telling me how many VLDLs plus IDLs plus LDLs you have. Once they exceed a certain threshold, the odds get higher, higher, higher as their concentration goes up, up, up. Then, oh my God, they're crashing my artery wall with the potential to create plaque. If I wanted to develop a therapy that would prevent plaque, I would somehow induce my liver into grabbing those ApoB particles and clearing them before they ever crash the artery wall. Mm-hmm. And every proven lipid medication that reduces heart attacks nowadays virtually works through that mechanism. Let's introduce it now. The protein that grabs ApoB and internalizes it into the liver is called an LDL receptor. It binds to VLDLs, LDLs, IDLs, anything with ApoB on it, it will bind to and clear. Mm-hmm. So it's not that tough a subject. How many ApoB particles you have, and are there dietary tricks to lower ApoB? Are there pharmacologic tricks to lowering ApoB? And the answer being yes. What we now know, didn't know decades ago, is forget about the HDL particles. Yeah, they certainly perform a ton of functions, none of which are measurable by current laboratory techniques available to the real world. So, and the old nonsense that low HDL cholesterol is associated with heart disease and high HDL cholesterol is not, it's just been disproven. It's a generality in general, yes, but in a given individual, your HDL cholesterol, even your HDL particle count tells me very little. Mm-hmm. We must focus on the ApoB story. So that's how you can start relating lipoprotein concentrations to atherogenesis. And for those who say, but I don't order ApoB, I don't order other techniques, LDL particle counts using other methodologies. I just do lipid concentrations. Better than nothing. Lipid concentrations like total cholesterol, LDL cholesterol, even HDL cholesterol are simply guesstimates of do you or do you not have too many ApoB particles.
Tom, 1 second. Before we get into the lab test and measurement of this, I just want to close out that we're done with the definitions. And what Tom just said, which is very important, and he just kind of said it, but for most people that still think that HDL is very important and a high HDL number is good for us, that story is no longer true. And we're trying to find out what the real story behind HDL is. But higher HDL does not mean you're in better health by any means, as far as we know.
Remember, when you see high HDL, you're either talking about HDL cholesterol, the cholesterol content in all your HDLs, or maybe you're talking about an HDL particle count done by other lab tests or an ApoA1. Mm-hmm. And the truth is, until we have tested, tell us how the HDL is performing, that's called HDL function. Is that HDL doing good stuff or bad stuff to our arteries? HDL cholesterol and HDL particle counts are useless.
Okay. That's very good to know, Tom. Thank you. The other thing that Tom mentioned is this ApoB particle or protein. And why that's important is he classified it as the proteins that have one of each ApoB on them, LDL, IDL, and VLDL. And LDL, most people know LDL is the bad guy, but what Tom is going to talk about in more detail is that VLDL, because of having the ApoB on it could also be causing damage to the artery wall. And so just understand that there's the IDL, HDL, and VLDL. So IDL, LDL, and VLDL, all of that, those have an ApoB on them. And the ApoB story is very interesting, and we'll get into measuring it because that's a direct, almost predictor of how bad you're doing.
One little asterisk for that statement. That is totally true what you just said, but here's the problem.
Okay.
VLDLs, when they enter the plasma, last for a few hours. IDLs last for 20 minutes. LDLs hang around for 3 to 5 days. So if I measure ApoB, 90 to 95% of the circulating ApoB particles are LDLs.
Okay.
So in essence, when you order an ApoB lab test, you're counting your LDL particle concentration. You're not getting usable information on VLDL particles or IDL particles. Even they're part of the polluting environment, but its LDLs are doing the most of the damage.
Okay. So Tom, to round out part one of this interview, I'd love to go over with you and get your color commentary on the standard lipid panel that most people get. Nobody, I don't think their primary care physician is asking for ApoB or LDL particle numbers. So I want to go through some of those metrics that people are getting, and then what they could do to get a better result, and what they can ask their physician or go directly to a company like Direct Labs or something to get the numbers that you're going to share with us. So let's start with triglycerides, total cholesterol is the first one.
Yes. And remember, going back to those young days in my medical school infancy, the only lipid that was being measured on blood tests was total cholesterol. And none of the subfractions were being measured for another 10 years. So what is total cholesterol? Remember, we're measuring the cholesterol that's floating in your plasma per unit volume. So in the United States, we take a deciliter of blood and we take the lipoproteins that are in it and saying collectively all of the lipoproteins in your bloodstream, and that would be VLDLs, IDLs, LDLs, and HDLs. Collectively, how much cholesterol are they carrying? And that's what a total cholesterol level is. Now, it's not a useless metric because the probably 75 to 80% of that total cholesterol is in your LDL particles, not in your HDL or VLDL particles. So in general, total cholesterol is a poor man's guesstimate of ApoB. And look, the first thing Framingham proved is total cholesterol is a absolute cardiovascular risk factor. Those guys knew they were measuring potentially atherogenic particles, but that's what total cholesterol, its current use is to give you, if your total cholesterol level is above a certain level, and that can be debatable, 150, 200, until you prove otherwise, you have too many ApoB particles. So that might spur you to do more advanced type of analysis of your lipid concentrations. So that's what total cholesterol is. Now we'll move on to what's usually given next in the lipid profile. It's either HDL cholesterol or LDL cholesterol. So let's get rid of HDL cholesterol because I hint that you better not be using it for too much. HDL cholesterol would be if I could take every HDL particle, whether it's eeny, weeny, mid-size, or large, out of a deciliter of your plasma, and I collectively weighed the cholesterol in those particles. That's what HDL cholesterol is. It's the total mass of cholesterol molecules trafficked within every HDL particle in a deciliter of your plasma. If you want to make a generality, yes, there seems to be less atherosclerosis if HDL cholesterol is high. There seems to be more atherosclerosis if HDL cholesterol is low. But that's a population generality that never, ever applies with certainty to an individual patient. So if you want to tell me everybody in your town has a certain HDL-C level, I might guess whether there's a lot of heart disease or not in your town. But if you tell me what your HDL cholesterol level is, what do I care? I got to look at other things more related to atherosclerosis. So that's HDL cholesterol. Now, how about LDL cholesterol? It's the one, oh my God, that's the one we better not have out of whack. Well, as you can probably figure out, if I could take every LDL particle out of a deciliter of your plasma, be it a tiny LDL, be it a big fat LDL, and I collectively extracted all the cholesterol molecules and weighed them, That's what LDL cholesterol is. It's the mass of all the cholesterol molecules trafficked within every LDL particle, regardless of size, in a deciliter of your blood. And guess what? ApoB is the nightmare, right? One of the, certainly way better than HDL cholesterol, infinitely better than total cholesterol. The single, I wouldn't say best because there's one better, but the tremendous correlation with ApoB, since I already told you 90 to 95% of the ApoB particles are LDLs. That's why LDL cholesterol is regarded as so dangerous. Because as LDL cholesterol goes up, 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 in general, ApoB goes up, 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 the driver of atherosclerosis. So LDL-C is just, again, a lipid profile metric used to estimate ApoB, potentially atherogenic particle concentration. We'll get into later discussions of what are the circumstances where LDL cholesterol might be high, but LDL particle concentration is not? Or is there a circumstance vice versa to that? LDL cholesterol looks perfect, but your ApoB or LDL particle count is high risk. Yes, that can occur.
Okay, Tom, what you're saying is that the total cholesterol directional number, off base, very off base, but directionally okay. LDL cholesterol, and for folks that are listening, it's LDL cholesterol, not just LDL, for you to understand what's coming out of these numbers. It's much closer. It's not perfect, but it's much closer and it tracks with heart disease directly. Now,
because it more accurately tracks ApoB.
Right. ApoB is the bad guy. So in terms of numbers that you like to see on we can forget HDL, but on LDL cholesterol, what is a good number that you like to see, knowing that it could be individual?
Well, it is, and it really determines, we use LDL cholesterol or ApoB for two reasons: to ascertain cardiovascular risk, atherogenic cardiovascular risk. And then once we ascertain, my God, you're at high or very high risk, we want to lower it, then ApoB or LDL-C is used as a goal of therapy. How well is your therapeutic suggestion working? So that's what they use. So if you told me you've already had a bypass and 3 stents, your LDL cholesterol has to be much, much lower than, hey, you're a young guy, you've had some imaging, there's no plaque in your body whatsoever, you don't have other cardiovascular risk factors. The LDL-C is not going to be as stringent or risky. So it's tough to tell somebody LDL-C is bad news or good news for you. But if we want to do that, hey, population percentile things, you know, if we look at almost any lipid metric, including LDL cholesterol, it's a bell-shaped curve. Most people in the population will be right in the middle. There'll be some people with much higher levels at the fringe part of the curve, and there'll be maybe some lucky people at the other end of the curve where the LDL-C or ApoB is low. In general, we know disease tracks with the higher concentrations. So a long time ago, they came up with, you don't want to be right in the middle of that curve because, you know, at least half of the people get atherosclerosis, for God's sakes. Right. They've declared a long time ago that, and Framingham backed it up a little bit, that if you could be in the bottom 20th percentile of ApoB or LDL cholesterol, you're probably going to be at a lot less risk. God forbid you're in the 80th percentile or higher of those absolute levels of those metrics. Mm-hmm. So if we want to look at that, you know, an LDL cholesterol of the 20th percentile, somewhere around 70, used to be 80 milligrams. It's dropping and dropping as we go on. So if you have an LDL-C under 20, you're in the bottom 20th percentile. Obviously likely to be a lot more risk than somebody who has an LDL cholesterol of 190, which is up in the 90th percentile. Mm-hmm. So if you're an LDL cholesterol of 100 to 110, you're right in the middle. And 50% of people get heart disease. So who the hell wants to have an LDL cholesterol of 110 without at least doing a more sophisticated test like ApoB to see whether that's accurate or not? So if, by the way, you are the guy with the bypass, we want your LDL-C well under 55 nowadays. Guidelines call for that because they're the ones more likely to have a heart attack than somebody who hasn't. So those would be the numbers with LDL cholesterol.
Okay, thank you for sharing, Tom. Now let's move on to the next number, which is, I believe, triglycerides, yeah?
Yes. By the way, the ApoB would be 80, bottom 20th percentile, under 60, really where you want to be.
And I want to get to ApoB separately because that's a different test, yeah?
All right, so triglycerides is the last lipid concentration you're looking at in your profile. So remember what total cholesterol is? It's the cholesterol within every darn lipoprotein circulating in a deciliter. That's what triglycerides is. It's every triglyceride molecule circulating within every lipoprotein in your plasma. So it's VLDL triglycerides, IDL triglycerides, LDL triglycerides, and HDL triglycerides. But the real triglyceride carrying the particles are the biggest, fattest, the ones that have a tremendous diameter. And that would be your VLDL particles. So most of the triglycerides, I told you most of the LDL cholesterol is, they're in the most of your cholesterol is in the LDL particles. Most of your triglyceride is in the VLDL particles. Typically, LDLs and HDLs carry very few triglyceride molecules. Unfortunately, in pathologic circumstances like insulin resistance, they acquire triglycerides, which is bad news. But triglycerides are the mass, the weight of triglycerides in all those particles. But most of them are probably going to be in the VLDLs. And that's why if you ate a meal and you start measuring triglyceride levels every 20 minutes for the next 6 hours, it goes up right away, but then comes right down pretty quickly. Whereas LDL cholesterol is a straight line because LDLs hang around for 3 to 5 days. There's no minute-to-minute variation. VLDLs, the liver produces them after you eat. The lipids go to the liver secretes VLDLs. The triglycerides goes up, but then the VLDLs, if they're functioning, go and dump the triglycerides in your muscles or fat cells. VLDLs disappear. So triglycerides goes down within 4 to 6 hours after a meal under normal circumstances. So that's why labs tell you if you want a triglyceride measurement, come in fasting. We don't have to deal with excess VLDLs.
Okay. So if you do go in fasted, Tom, and let's say it's a 12 or 14-hour fast and your triglycerides are still high after that number, what does that mean?
Well, it means you have triglyceride-rich lipoproteins, doesn't it, that probably aren't being catabolized as rapidly as they should. So then you have to figure out, God, is my liver overproducing these? Or for some reason, they're not effectively delivering triglycerides to where they should be. And that means they're not losing their triglycerides. The enzymes that extract triglycerides from these particles are called lipolytic enzymes. They dissolve the triglycerides that can then leave the particles and go where they're supposed to go. But if you have interference with that process, the VLDLs are never going to give up any of their triglycerides, and they're going to float around longer, and your triglycerides will be raised. Here's what most people don't know, because even today, your lab tells you, oh, triglycerides become a problem when they're over 150 milligrams per deciliter. Oh my God. If you want to do that bell-shaped curve with triglycerides, if you have a triglycerides of 75, you're hitting the 50th percentile. You hit a triglycerides of 130, you're into the 80th, 90th percentile. Yet most people think if they have a trigs of 130, I'm home free, I'm fine. They may be, they may not be. But I believe if we're just going to make generalities of lipid concentrations, we have to really lower the bar on what a physiologic triglyceride. A physiologic triglyceride is well under 70 milligrams per deciliter.
Okay. And folks listening, that is why this field, it's complicated. Not every physician or doctor knows the intricacies or the nuances of this field like a world-class expert like Tom. So please listen to this carefully and make sure. We're going to talk about a couple more tests that Tom likes. We'll get into those and how you can get those. So Tom, let's touch on ApoB and LDLP and which one first of all, what are these and which one you prefer over the other?
Right. Quickly finishing up on triglycerides, if you want to use it as a generality, as it goes up, certainly 110, 130 and above, you better go do an ApoB test to see, because the odds are good. And that's one of the reasons triglycerides is such a serious risk factor, because it's telling you they have too many of those ApoB particles. But what do the ApoB particles deliver to your artery wall that causes atherosclerosis? Not triglycerides, cholesterol.
Cholesterol, yeah.
So triglycerides is another thing to say, I may have the wrong type of particles in my body. All right. So you better understand the lipid concentrations, how to extrapolate. I guess we must go one more lipid concentration you forgot to mention. And it's a calculation. Most labs report it's called non-HDL cholesterol. And what is that? It's just what it says it is. It would be the cholesterol that is not in your HDL particles. If cholesterol is not in an HDL, what does it have to be in? An ApoB particle. predominantly LDLs, but it could be in VLDLs or IDLs also. So non-HDL cholesterol calculated by dividing or subtracting HDL cholesterol, the cholesterol that's not in your ApoB particles, from total cholesterol, the cholesterol that's in every particle. The number you wind up with is your ApoB cholesterol. It's the cholesterol not in the HDL. So it is actually the best surrogate in the lipid profile to clue me and you in that, oh my God, we're dealing with ApoB excess in this person. And guidelines have introduced non-HDL cholesterol now pretty much as a secondary goal of therapy. Don't think you get LDL cholesterol and you're home free unless you also get non-HDL cholesterol home free. I would say just get ApoB home free and forget the cholesterol metrics.
I love that you're calling these ApoB particles, because then it's now clear to me that everything other than HDL, IDL, LDL, VLDL is all ApoB. So instead of saying all those individual particle names, you just say the ApoB particle.
Correct. And that's what makes ApoB so beautiful.
Yeah.
And and maybe next time we'll talk about Lp(a). That's in the ApoB family too. Most people don't have it, but many do. But that would be another contributor to ApoB.
Yeah, and from what I understand, and we'll get into this next time we have this. So anyway, let's table the LPA discussion because that's a whole can of worms. But Tom, we were going to talk about LDLP, right. ApoB. Please explain what those are.
Sure. So obviously, I think listeners now know that if I ask a laboratory to report ApoB, they're counting the ApoB molecules that are on whatever's floating, whatever lipoprotein is floating in my bloodstream. And ApoB is going to be on every VLDL, IDL, LDL, Lp(a), and it's not going to be on an HDL. So ApoB is how many of these potentially atherogenic particles, meaning they do have the ability to leave plasma, enter your artery wall and pollute it with cholesterol, how many of those do we have? Rather than guess it by looking at LDL cholesterol, total cholesterol, or non-HDL cholesterol, why not just measure ApoB, which is an accurate way to count those? And I've already hinted that once you count ApoB, 90 to 95% of them, unless you have some bizarre condition, are LDLs. So ApoB is really what we now call an LDL particle concentration, LDL-P. Now, there are other laboratory methods that can report an LDL particle number that don't rely on ApoB. I don't need to get into the way those assays are performed, but at the end of the day, ApoB tells me how many LDL particles you have. But if I use nuclear magnetic resonance, NMR, they tell me, here's your total LDL particle count, highly correlated, just like ApoB is with atherosclerotic heart disease. And there's other laboratories out there that use a different methodology. It's called ion mobility transfer, that they can also report to you, this is your LDL particle count, which again has good correlation with atherosclerotic risk. So I want to see, no matter what your lipid profile shows, that you have, I want an ApoB and LDLP by either NMR or ion mobility. NMR has been around a lot longer, has a lot more data. So if I wasn't using ApoB, I would prefer NMR to ion mobility. But listen, it's a decent test. If that's, sometimes the third-party payer tells you what test you have to get done, not yourself. So it comes down to, let's say I want an ApoB or an LDLP by NMR. Okay. Personally, I've traveled the world teaching LDLP by NMR. I know a lot about it. I know all the studies, and it's a very decent test. But the world has moved on, and guidelines, which never ever talked about particle concentrations, ApoB, LDLP, now realize that's the whole ballgame. So they're starting to incorporate in their guidelines direct metrics of lipoprotein concentrations. And the one every guideline uses is apolipoprotein B. They don't use NMR for a variety of reasons. It's never been standardized. It's a proprietary metric only done by certain laboratories. Guidelines are never going to recommend it. You have to go to this lab, which my brother owns or something. Right. So ApoB is done by every lab in the world. It's, the assay is pretty solid. So since guidelines are reporting on that, I think that's the way to go. We can get into higher laboratory technical discussions on is ApoB more accurate than NMR, LDLP. I think there are certain circumstances where it is, but that's not for today's podcast.
Yeah.
So I think ApoB makes the most sense for a lot of people. And by the way, of ApoB, LDLP, NMR, LDLPI, and mobility, ApoB is infinitely cheaper than those other two tests.
Yeah.
And many third-party payers don't want to pay for a lipoprotein particle test. So ApoB should cost you $20 out of your pocket if you had to pay cash for it. The other ones, you're crossing $100 threshold. You know?
Okay. Yeah, I was actually exploring those this week as we're emailing. I'm going to get my ApoB. That's what Tom recommended I get. And so to round this up, Tom, we're going to close out. We're over time on the first segment. But on the standard lipid panel, which you get from your doctor, there are 3 numbers that should cause you concern if they're high. One is the total cholesterol, not total, triglyceride number if it's high, the LDL cholesterol if it's high, and the non-HDL cholesterol. If those 3 are high, then you got to go do an ApoB. Is that fair?
Yes, unless you could say they're astronomically high, because then the odds are ApoB is also going to be astronomically high. But most people have these gray zone total cholesterols, LDL cholesterols, So is ApoB really high or not? Because although they usually correlate, sometimes they don't. And that's when you need to rely on the particle number. So yeah, that's a decent summary. And by the way, low HDL cholesterol, which I sort of said, don't worry about it. If it is low, which certainly has epidemiologic evidence that you might be at risk, virtually every single person with low HDL cholesterol who's going to have a heart attack has a high ApoB. So even a low HDL cholesterol should be a clue to you is, do I have high ApoB or not?
Okay, so Tom's recommendation, I don't want to put words in your mouth, Tom, but always get an ApoB when you're getting a test. It's cheap and it's way more accurate than some of these other metrics. Is that fair?
Yes, it is. Many persons, unfortunately, let me just warn you, there's a ton of doctors out there who have never heard of ApoB or don't know what it is. But it's like everything else nowadays with social media. You can go educate yourself. You can bring your doctor's peer-reviewed articles. You can bring your doctor guidelines that say, hey, this is a test I need.
Okay, fantastic. So we're going to close out part 1 of this interview. Tom, thank you so much for breaking it all down, explaining the nomenclature, the lipoproteins, the LDLs and lipids. Sorry, not LDLs, lipoproteins and lipids, and what those really mean. And we talked about the standard metrics and enhanced metrics that you should get every time you go get your blood test done with your doctor. Now in part 2, we're going to dovetail a little bit more into the LDL itself. We're going to talk in more detail how atherosclerosis happens, what's the role of cholesterol, and how it's regulated in your body. And then we'll end part 2 with Tom's recommendations on how you can use diet, lifestyle, or even pharmaceutical substances to lower some of these high numbers if you have any. Is that fair, Tom?
Sounds good.